Chronic kidney disease. Definition. Chronic kidney disease is an umbrella term that describes kidney damage or a decrease in the glomerular filtration rate for 3 or more months. Chronic kidney disease represents a progressive decline in kidney function due to a permanent loss of nephrons. Stages. The stage 1, glomerular filtration rate more than 90 milliliters per minute despite kidney damage. Kidney damage with normal or increased glomerular filtration rate. In stage 2, mild reduction of the glomerular filtration rate, less than 19 but more than 60 milliliters per minute. In glomerular filtration rate of 60 milliliters per minute, the kidney may present 50% of his function. The stage 3, moderate reduction, when the glomerular filtration rate reduced till 30 milliliters per minute. Stage 4, severe reduction of the glomerular filtration rate, less than 30 milliliters per minute but more than 15 milliliters per minute. And stage 5, this is the end-stage renal disease. This is the rarely kidney failure when the glomerular filtration rate less than 50 milliliters per minute. Chronic renal failure or end-stage renal disease is a progressive, irreversible deterioration in renal function in which the body's ability to maintain metabolic and fluid and electrolyte balance fails, resulting in uremia or azotemia. It means retention of urea and other nitrogenous wastes into the blood, and necessitates renal replacement therapy on a permanent basis. It's the third and the final stage of chronic kidney disease, also called as end-stage renal disease. The causes of the chronic kidney disease can result from a number of causes, including, in most of the cases, the diabetes mellitus and hypertension. The chronic kidney disease can be after acute renal failure, after the systemic lupus erythematosus, the chronic glomerulonephritis, polycystic kidneys, after the nephrotoxic agents, and during the kidney stone disease. Stage of the chronic renal failure. We reduced renal reserve, 40%, 75% loss of nephron function. Patient is asymptomatic. Renal insufficiency, 75%, 90% loss of nephron function, 25% of normal renal function. It's enough, but during this it will be mildly elevated creatinine and blood urea nitrogen, impaired urine concentrating ability and anemia. Sometimes maybe dehydration. During the end-stage renal failure, the final stage of chronic renal failure, less than 10% of nephron function remaining. All of the normal regulatory, excretory, and hormonal function of the kidney are severely impaired. Elevated creatinine and blood urea nitrogen levels, as well as electrolyte imbalances, we can reveal in these patients. Pathophysiology. Deterioration and destruction of nephrons. It can lead to the progressive loss of renal function, decreased glomerular filtration rate and clearances ability reduced, increased blood urea nitrogen and creatinine. Remaining functional nephrons will be hypertrophy. Kidney will lose their ability to concentrate the urine and reabsorb electrolytes. The urine will be very, very diluted, and sometimes we say that this is the polyuric phase of the chronic kidney disease. Then further damage to kidney and glomerular filtration rate will be decreased, and after all of this, the uremia or death occur. Clinical manifestation. It may be neurologic, neuromuscular, cardiovascular, respiratory, gastrointestinal, hematologic, as anemia, skin, bone diseases, and sexual dysfunction. treatment, conservative treatment, dialysis, and transplantation. Dialysis. What it means? It means that it removes waste, salt, and extra water to prevent them from building up in the body. Keeps a safe level of certain chemicals in the blood, such as potassium, sodium, and bicarbonate. Helps to control blood pressure. Hemodialysis. This is a procedure in which a machine filters harmful waste and excess salt and fluid from patient's blood. A needle is inserted into the arm through a special access point. The arterial blood is then directed through the needle to a machine called a dialyzer, artificial kidney, which filters the blood. The filtered blood returns to the patient's venous blood through a nasocut needle. Vascular access for dialysis. We have the temporary access, AV fistula, arteriovenous fistula, and arteriovenous graft. Temporary access we perform through the catheter, which is inserted into a large vein, neck or groin. Arteriovenous fistula. This is the connection between an artery and a vein, usually in the forearm. It's most used method for dialysis, and we can use this method maybe in much more cases patients. And arteriovenous graft. If blood vessels are too small to form an AV fistula, the surgeon may instead connect an artery and a vein with a synthetic tube. This tube functions like an artificial vein, usually in forearm or upper arm. And AV graft often heals within 2 to 3 weeks. Now, you can see the AV fistula when the wall of artery and the vein is connected, and after 3 weeks or 1 month, the vein will be dilated, and this dilatation is enough in order to needle puncture and take the blood, enough blood for dialysis machine in order to perform the dialysis. One session of dialysis can last till 4 hours, 2 or 3 times in a week. Complication of hemodialysis. This is the technical problems, hypotension or hypotension, febrile reaction, arrhythmias, hemolysis, and hemorrhage. Peritoneal dialysis. It doesn't use an artificial membrane, but rather uses the lining of the patient's abdominal cavity, known as the peritoneum, as a dialysis membrane. Access. The peritoneal dialysis requires intraperitoneal catheter, which can be introduced only by surgical operation with laparotomy. Procedure. Dialysate is instilled through the catheter into a peritoneal space, is left to dwell, and then drained. In the double bag technique, the patient drains the fluid instilled in the abdomen in one bag and then infuses fluid from the other bag into the peritoneal cavity. Complication of peritoneal dialysis. This is peritonitis, catheter-related complication, dialysis-related complication. And kidney transplantation. Kidney transplant provides better long-term survival and improved quality of life compared to dialysis. Patient survival and transplant success has been progressively improving over the years. Kidney transplant is the treatment of choice for the end-stage renal disease in eligible patients. History. In 1902 years, the first successful experimental kidney transplants were performed at the Vienna Medical School in Austria with animals. In 1909, the first kidney transplant experiments were performed in humans in France using animal kidneys. In 1933 year, the first human-to-human kidney transplant was performed, and known to doctors at the time, there were mismatches in donor and recipient blood groups, and the donor kidney never functioned. In 1940 years, Sir Peter Medway at the University of London experimented with the immunologic basis of organ rejection. Early 1950s, cortisone-like medications were used to suppress the human body's self-defense system, immune system, resulting in some kidney transplant success. In 1954 years, Joseph Murray and his colleagues at Peter Bent Brigham Hospital in Boston performed the first truly successful kidney transplant from one twin to another. This was done without any immunosuppressive medications. Indication for the kidney transplantation: end-stage renal disease when glomerular filtration rates less than 15 milliliters per minute, malignancy, hypertension, diabetes mellitus, genetic disease, polycystic kidney diseases, metabolic disorder, and chronic renal failure. Contraindication: cardiac and pulmonary insufficiency, hepatic diseases, concurrent tobacco use, and morbid obesity puts the patients at risk for surgery, and human immune deficit syndrome. Benefits and risks of kidney transplantation. The benefits: significantly reduced risk of mortality. The life expectancy can triple. Reduced risk of heart attack, stroke, and heart failure. Kidney transplantation reduced infection-related hospitalization, improved quality of life, and more likely to stay employed for the patients. The risk of this procedure: the acute rejection of early. Anti-rejection medications affects the infection, some malignancies, especially skin cancer, increased risk of diabetes, high blood pressure, high cholesterol. Graft can be lost over time. Overall, in eligible candidates, the benefits of kidney transplantation far outweigh the risks. Early transplant. More benefit to early transplantation once dialysis started. It improved graft survival if transplanted in first 6 months on dialysis, and improved patient survival if less than 1 year. Better long-term graft function the early transplant occurred. Preemptive transplant. The transplantation before dialysis started. Many benefits including decreased rejection rates by 25%, improved graft survival long-term, improved patient survival, less delayed graft function, and decreased overall hospitalization. Living donors. Evaluate living donors on physical, medical, and psychological grounds. Assure at the patients that there will be no long-term harm to donor. In some cases, male living donor may develop a hydrocele on the scrotum on the side of nephrectomy. Live donor procedures are mostly laparoscopic, hence less painful, less scarring, and faster recovery. Deceased donors. We can use the brain dead donors and donation after cardiac death. Brain dead donors or beating heart donors are considered dead, but the pumping heart continues to perfuse the other organs. Donation after cardiac death are elective donation of organ by patient himself or the relatives to withdraw life support as they have slim chances of survival. Compatibility. The patient has to be AB0 compatible. The recipient should share as many as HLA antigens and minor antigens as possible. Immunosuppressant drugs are given to prevent antibody reactions, and we have to perform antibody tests on potential recipient. Post-operation. The operation duration is around 3 hours approximately. Donor kidney will be replaced in the lower abdomen. Arteries, veins from the recipient's body is connected to new kidney, and the final step, the ureter of the new kidney connected to the bladder. New kidney starts functioning immediately. Living kidney may take 3 or 5 days, and cadaver kidney may take up to 7 or 15 days. Complication of a kidney transplantation. Of course, the first is transplant rejection, infection and sepsis, post-transplant lymph-proliferative disorders, electrolyte imbalances, and iatrogenic side effects. Prognosis. Kidney transplantation is a life-extending procedure. A patient may live up to 15 years longer with a kidney transplant than if kept on a dialysis. Patients will have more energy, a less restricted diet, and fewer complications with a kidney transplant. Summary. The best treatment for end-stage renal disease is transplant. Kidney transplant saves lives, improves quality of life, and saves costs. Living kidney donation is safe and provides better outcomes. Preemptive transplantation is best, but also advantageous to early transplant once on dialysis. Thank you for listening.